following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. Support for this episode has been provided by independent educational grants from Lantheus Medical Imaging and Novartis Pharmaceuticals Corporation.
Good afternoon. My name is Jay Rahman, and I am professor of urology at Penn State Health and chair of the AUA's Office of Education. It's my pleasure to host another episode in our Office of Education podcast series, with this specific podcast being one of several in a series called Discussions in Prostate Cancer. Today's specific episode is titled Treatment Intensification in Metastatic Hormone-Sensitive Prostate Cancer. And it's really my pleasure to have as guest Dr. Dave Gerard. Dr. Gerard is a tenured professor and vice chair for the Department of Urology at the University of Wisconsin. And he's also the deputy director of the Carbone Cancer Center at the University of Wisconsin. He is a well-known thought leader in the field of prostate cancer, having served on guidelines panels for both the National Comprehensive Cancer Network and the American Urological Association. He served as a clinical trial investigator on several different studies, with some work supported by the RO1 mechanism through the NIH and the Department of Defense, and has really been a big supporter of the AUA, having led our advanced prostate cancer course, which has been enormously successful for a number of years. So, Dave, thanks again. I know you've got a lot of things on your plate. We, of course, appreciate you taking 30 to 40 minutes of your time on these busy days to speak to our audience.
Well, thank you, Dr. Rahman. And it's a real pleasure to be here, get a chance to talk some about prostate cancer, which there are a lot of really remarkable changes in this field over the last several years. I think back to the beginning of my career, and we essentially had one drug for advanced prostate cancer. Now there are 14 FDA-approved drugs for advanced prostate cancer, and certainly sitting on the guidelines panel for the AUA and the SUO, we pretty much have to update these guidelines every couple of years. And certainly for the listeners, I'd encourage them to refer to some of the latest updates to the advanced prostate cancer.
So maybe before we dive into sort of some of the specifics regarding, the concept of treatment intensification, maybe give us the big picture overview of what we're going to talk about maybe over the next 30 minutes or so. And then that may help us with the framework of as we sort of talk in greater detail where we're coming from and maybe some of the details.
Yeah, so I think we'll spend some time talking about the pathophysiology of metastatic hormone-sensitive prostate cancer. And it's certainly important to understand the rationale for why we undertake treatment intensification in these patients. Certainly, this field of hormone resistance is very important to understand that the androgen receptor still plays an important role in this. So we'll talk some also about different types of treatment intensification. It's basically combining things with androgen deprivation therapy, and then also discuss the criteria for establishing or selecting patients. This includes things like disease burden, patient comorbidities, and individual risk profiles.
No, that's great. I think great sort of overview of what we're going to cover. So, I'll maybe just knowing that our audience is truly a spectrum of people that listen to the program, I'll maybe just start off and maybe just have you define just a few basic things, and then maybe we'll talk about some of the recent developments. But we use this term advanced prostate cancer. I mean, obviously you teach a course on advanced prostate cancer. The AUA guidelines talk about advanced prostate cancer. Just briefly for our listeners, what when we use the term advanced prostate cancer, what are we talking about? Just broad entity, just from your perspective, what does that mean? What does that term mean?
So these are patients farther along the natural history of the disease. And typically, these are patients in which the risk of metastatic disease is much higher. There are we think mainly in terms of hormone-sensitive prostate cancer, and this is cancer that's not yet been treated with androgen deprivation therapy. It's still responsive to that. Obviously, a little farther along is castration-resistant prostate cancer, and these are individuals who have been treated with androgen deprivation therapy, but they have a castrate level of testosterone below 50 nanograms per deciliter. So it's important. That's when we're thinking about advanced prostate cancer, that's sort of the area we're working in. Volume is important as well, and we can talk a little bit more in the podcast about different definitions of high volume, low volume cancer.
So, yeah, that was great. You sort of put into context this sort of verbiage of advanced prostate cancer, and if we talk about sort of patients presenting with metastatic disease, I'm sure you'll tell us. I mean, that can obviously happen in two different scenarios, right? Somebody that walks into your office who has evidence of metastatic disease versus somebody that's kind of gone through this entire continuum and over time has developed. Maybe talk to us about those two different presentations, and in your mind, how does the strategy perhaps differ, and how do we think about using things like imaging and the importance of genetics in this sort of space of metastatic prostate cancer?
Yeah, you bring up an important distinction, and clearly, when we look at the response to our treatments, patients that present with de novo metastatic prostate cancer, that is, as you mentioned, walking off the street, found to have a PSA of 40 or 50 or 400, these patients actually do much worse stage for stage, grade for grade, than patients who have essentially recurred or failed primary therapy. And so much of our treatment intensification, especially when we talk about triplet therapy, is more focused on these patients. Now, it's also important to realize that there's been a change in the prevalence of advanced prostate cancer presentation, and this has been a trend that's occurred over the last several years. So we can all think back to in the early 2000s when there was a shift in screening, and the U.S. Health Preventative Task Force essentially gave PSA screening a D rating. The number of patients that actually were screened dropped fairly significantly. And what we're seeing now is potentially a result of that. It's not completely, part of it may have to do with some of the deferred care during the pandemic as well, but patients are presenting with distant and regional advanced prostate cancer much more commonly than in the past. And that rate has been increasing about 5% per year. Now, I'd point out that this is actually before PSMA PET imaging began to be widely used. So that did not necessarily impact this. The other important feature to realize about this is that our Black patients, this incidence of prostate cancer is about 70% higher for a number of different reasons. And so that's one group that's especially being harder hit with this more advanced prostate cancer. But on the flip side of it, is that men with de novo hormone-sensitive prostate cancer survival is improving. And some recent data, actually, there was a paper hot off the press looking at in JAMA Network Open, looking at survival over the last 10 years. And since we've begun using doublet therapy, that's improved about anywhere from 5 to 8%. And so it's clearly having an impact on the management of these patients. But you essentially talked, and we can certainly talk a little bit more about some of these features with regard to evaluation. But those are just globally some of the trends that are occurring right now in advanced prostate cancer.
So you identified and you sort of defined for us early on, when we talk about metastatic prostate cancer, sort of the two big maybe entities, hormone sensitive and then castration-resistant prostate cancer. And you very nicely sort of defined just with testosterone levels how you differentiate between the two states. Maybe talk to us a little bit about two questions. One is the general timeline that somebody may evolve, and I realize it's a spectrum, but the timeline that somebody may evolve from hormone-sensitive disease to castrate-resistant, just, what sort of timeline are we looking at? And then more importantly, which I think ties into that, is what is the mechanism? Like, why does this occur? What is this change or this switch that flips? So maybe timeline and mechanism, if you can, just talk to us about that.
So traditionally, in a patient with an advanced prostate cancer, metastatic hormone-sensitive prostate cancer, the average survival was somewhere in the range of 30 to 32 months. With the advent of some of this treatment intensification, a lot of our newer drugs, we're pushing it even above 40 months now. So just to give you a sense of how this is beginning to change the field. So when we think about mechanistically, one of the really striking basic discoveries was that in patients with advanced castration-resistant prostate cancer, they still express the androgen receptor. And that in about 70% of these patients, the androgen receptor is overexpressed. So this kind of androgen receptor amplification, presumably this would make it more sensitive when it comes to utilizing low levels of androgens that are around in these castrate-resistant patients. It's also important to realize that the androgen receptor can bind other types of hormones, including adrenal androgens that are converted. There are mutations that occur in the androgen receptor, making it much more promiscuous when it comes to binding other types of glucocorticoids and adrenal androgens. And then finally, there are these androgen receptor variants, probably the best known as ARV7, which can sort of auto-activate the androgen receptor. That's, they don't need the ligand to actually turn this on. So a lot of the drugs that we're using currently target these mechanisms. For example, abiraterone really focuses on the adrenal androgens. These drugs like apalutamide, darolutamide, enzalutamide focus more on inhibiting the translocation and binding of the androgen receptor. So when we think about the management of this disease, it's important to have that context. Now, those are all ligand-dependent mechanisms for castration-resistant prostate cancer. They're a whole other sort of area of ligand-independent areas. And since we don't have much in the way of targeting for that, we'll sort of leave that out of this discussion, but just be aware of that for the listeners.
And then sort of, I think maybe one related, and I feel like it's a message that we have, I think, continued to try to underscore in a lot of our programming here. And I think it's still it's a great deficiency, is just briefly talk to us about, as we identify and see these patients with metastatic prostate cancer, regardless of how they get there, and we're thinking about active therapy, just briefly talk about just the importance of germline testing in these patients, and in your practice, when does that occur, and maybe just talk briefly about how that conversation occurs or goes with your patients.
Yes, so it was really a striking discovery a number of years ago, and it was about 7 years ago when finally the correct study was done, which in patients who died of prostate cancer, metastatic castration-resistant prostate cancer, they actually went through and sequenced these tumors, as well as sequencing the germline of these patients. So essentially looking at the white cells. What they found was that a large percentage of these patients, and it was about 25%, had DNA repaired gene alterations or defects. These included genes like BRCA2, which was the most common, there's a breast cancer gene, ATM, CHEK2. So the other interesting thing was germline mutations, that are sort of running through these families, were found in about 8 to 12% of these patients. So it really suggested that when we think about family history and prostate cancer lethality, we need to take a very careful history, not only talking about prostate cancer, but also some of these familial syndromes, thinking of early breast cancer, ovarian cancer, pancreatic cancer. So it's really changed the way we think about this. Now, it's important for every patient with advanced prostate cancer to have at least a somatic testing of the tumor. If you look at our guidelines, that's an important part of this. And the reason for that is we now have drugs that in patients with more advanced prostate cancer are approved for patients with these DNA defects, DNA repair defects. There's rucaparib and olaparib, or two of these. These are PARP inhibitors that are specifically approved for patients with these kinds of DNA repair defects. So we're beginning to see the advent of targeted therapy moving into this field of prostate cancer.
So, we've talked a little bit about some broad principles here. So maybe I'll kind of throw a case at you, and you can kind of walk us through how you think about this and the things that you would do in your practice just as this person. So let's just say we've got a guy in his early 70s, 72, who has PSA of 40. So let's say bulky grade group 4 prostate cancer. Just walk us through. All right, this person sort of comes into your clinic as a referral, and already obviously, there's a lot of high risk features, both from PSA, both from biopsy. But Dave, walk us through a little bit. How do you evaluate this person, and what goes through your sort of thought process and the decision making there?
Yeah. So in this 70-year-old patient. Obviously, one of the initial things is histologic confirmation, and we're already have some imaging. It sounds like there is metastatic disease. So making sure we obtain a tissue diagnosis either from the metastasis or the primary tumor would be important. And in this kind of situation, it's just whatever's easiest. Okay. So we're fine with either. Then I think it's important to think about treatment discussions. And, this is all based on things like life expectancy, comorbidities, other aspects of individual patients. And, realize that the potential for full expression of this disease is limited by the likelihood of dying from other types of cancer. So if this is an individual has other significant comorbidities, you may think a little bit differently about treatment intensification versus somebody who is younger and healthier or just healthier. It's also important to incorporate a multidisciplinary approach. And clearly, with the advent of this increasingly complex therapeutic landscape, it's important to sit down and talk with urologists, our medical oncologists, radiation oncologists about the management of these patients. And we even include genetic counseling and in some situations palliative care in these discussions. But that's all important. And then finally, another aspect is just pain control. So this individual just getting a sense of how much discomfort they're having, and this is important with regard to, and also urinary symptoms. That kind of symptom management is critical. So typically for this patient, we would probably lean towards, and it sounds like they had a CT scan, but there really has been a shift towards employing next generation PET imaging in these types of patients. And the prostate-specific membrane antigen is really being used much more broadly now in this modern era. Previously we had very early efforts at this, choline PET, which was difficult for people to access because there are only a few synthesizers here in the United States, and it had a very short half-life. Flucyclovine was more widely used. It's imaging amino acid metabolism, but it was nowhere near as sensitive as the prostate-specific membrane antigen. And again, this is a transmembrane protein that's expressed by these cancer cells, and this is targeting this. So this was FDA approved about 3 years ago, and has really changed the way that we think about prostate cancer in both positive ways, but also it's created some controversy with regard to many of the studies in the past that we've done have utilized conventional imaging, CT scan and bone scan. So our guidelines say that in this kind of metastatic patient, we should probably obtain a PSMA PET scan instead of conventional imaging. And certainly our guidelines talk about the fact that with biochemical recurrent prostate cancer, that is important. But one of the controversies that comes up is if you have a positive PET, negative conventional imaging, what do you do in that situation? And it's kind of, and realize that there can be false positives with PSMA PET scanning. Things like Paget's disease can create false positives, for example. So in that kind of setting, we often lean more on the conventional imaging with regard to that, but place it in the context of the patient as well. So our patient we definitely get a PSMA PET scan in this kind of situation to help us further evaluate that. And we talked some about genetic testing as well for this individual.
I think you brought up some really good points, and maybe just sort of touch on a few of them and just specifically pick your brain. A lot of the definitions when we look at burden of disease and some of the treatment response historically has been based on conventional imaging, generally CT or MRI, CT more commonly than MRI, plus typically bone scan, technetium bone scan. And so obviously we are in some regards, we are using PET-based imaging to define burden of metastatic disease, but it may not be necessarily apples to apples, right? What we're picking up now may be and probably is a different entity than what one have picked up historically on conventional imaging. So maybe just briefly talk about that a little bit. I know it's our new norm, and as you highlighted, it's in our guidelines, but it also sort of calls to question a little bit, are we going to have to, as we look future-wise in studies, are we going to have to sort of redefine treatment success based upon this new type of imaging? Maybe your broad thoughts on that.
Yeah, you bring up a great point, Jay, and that if you look at the detection levels of any metastatic disease in prostate cancer, it's about 25-30% higher with PSMA PET imaging. So it's really, and we have these discussions in our multidisciplinary meetings all the time. We had one yesterday debating about how to manage these patients, since we're finding disease in places we don't really expect it to be, in patients that would have been conventionally just treated with radiation. So it has changed the way we're approaching this. And one response to this is there are a number of trials going on right now looking at treating metastatic disease with stereotactic radiation. So just focusing on these metastases that we're picking up with this in an effort to delay systemic therapy. And so that's going to be an area that's ongoing right now. But for the time being, many of these trials that we'll be talking about here in these next couple of minutes, remember, most of them were done with conventional imaging, and we're transposing a lot of this data to that in the PET era. So stay tuned with regard to more information regarding staging and those types of patients that may necessarily benefit from different approaches.
So a little earlier, you talked a little bit about, you mentioned doublet therapy, and then, obviously there's triplet therapy, and a lot of this is in the realm of looking at, conventional ADT, some of the novel hormonal therapies on the androgen receptor, as well as systemic chemotherapy. Maybe talk to us a little bit about, this treatment intensification, doublet, triplet. What do we use, and in what scenarios do we think about these? And I know it's a broad question, and a lot of these are probably nuanced, patient specific, but just give us a broad sense of how you put all this together.
Yeah, so traditionally, androgen deprivation therapy has been delivered as monotherapy. So, either with these GnRH agonists or antagonists, and that has provided a benefit to patients, but over a period of time, and it's usually several years, they develop resistance. Now, in our guidelines, we're really recommending, if at all possible, doublet therapy should be considered for patients with metastatic hormone-sensitive prostate cancer. And that's in either the form of androgen pathway-directed therapy, things like abiraterone, apalutamide, enzalutamide, or androgen deprivation therapy plus chemotherapy in the form of docetaxel. Now, the first study that was really done was the CHARTED trial, looking at androgen deprivation therapy plus docetaxel chemotherapy. And I was actually a co-investigator on that trial. When we sort of initiated it 20 years ago, there was a lot of, it was a little unclear, the rationale for that. It wasn't the strongest rationale, except we used docetaxel in more advanced disease, and we're moving it into an earlier time in the disease. But it turned out to be resoundingly positive and led to an improvement in survival overall of about 14 months in these higher volume patients. And in the world of sort of advanced prostate cancer, that was a real win. So that was really the first discovery. And it's important to realize that there was a key stratification factor within that study. And that basically was based on conventional imaging, high volume versus low volume. And that was defined as high volume was essentially 4 bone lesions with at least 1 lesion outside of the vertebral column, so a greater than 4 bone lesions, or the presence of visceral metastases. So the patients that benefited the most were actually the worst patients when it came to doublet therapy, the so-called chemohormonal therapy. So we then, there was a series of studies done over the last 10 years, phase 3 studies. The first of those was using abiraterone, which is an androgen pathway inhibitor. And that, again, demonstrated a marked improvement in overall survival, radiograph progression-free survival, also just pain improvement in patients that got this kind of doublet therapy. And that has indeed been expanded now in several other additional trials, one using apalutamide and the other using darolutamide, to again solidify this as therapy for patients with metastatic hormone-sensitive prostate cancer. Now, a more recent development has been, well, if doublet therapy works, what if we did triplet therapy? And so this basically consists of essentially, there was a study, the ARISENS trial, looking at androgen deprivation therapy, docetaxel, and darolutamide. And again, it was a plus or minus the darolutamide. And again, these patients really benefited from this kind of treatment intensification. Now, realize that these patients have to be chemo fit. And we know that patients with very aggressive features, visceral metastases, high volumes, generally do very poorly on androgen deprivation therapy alone. But there was a marked improvement in this triplet therapy. Another study that took a slightly different approach to this was the PEACE-1 trial, where patients were given androgen deprivation therapy, abiraterone, and some of the patients also got radiation and docetaxel then, and some of the patients also got radiation therapy. This trial was a bit challenging because there were a lot of different arms to it. But in some of the aspects of the trial that have been analyzed so far, it's demonstrated a benefit to docetaxel, abiraterone, and then standard androgen deprivation therapy. So triplet therapy is being recommended by our guidelines for patients with de novo high-risk metastatic prostate cancer, if they're able to tolerate that.
So you sort of in that last segment, you brought in the question of radiation therapy. And so, I'll sort of throw it out to you. Talk a little bit about, where does, for metastatic prostate cancer, where does radiation fit in? Maybe talking both about radiation of the primary, and then maybe, as you alluded to, SABR or stereotactic radiation of sites of metastasis. So what's the data on that?
Yeah, so the radiation is approved for selected patients with metastatic hormone-sensitive prostate cancer. And basically, these are patients with low-volume metastatic disease. And the trial that was done, there were essentially two trials. One was arm H of something called the Stampede trial, which was a large trial done in Europe where they had a control group and kept adding sort of different types of therapies to a treatment group. It was really unique design, but that demonstrated there was a clear advantage to patients with low volume metastatic disease, and these are generally patients with pelvic metastases, although some patients that might, again, the low volume was based on the definition of the charted. And what they were able to show is that these patients benefited from the treatment of the primary. And that's important from just the standpoint. We've always believed that the primary prostate could continue to not only create local symptomatology with, bleeding, urinary obstruction, pain, but could also continue to shed cells. And there have been a number of studies that have looked at this issue of waves of metastases that continue to be shed from the prostate, the primary prostate, during the patient's lifetime. And as we come up with better treatment options, the control of the primary is becoming more of an issue. So radiation to the prostate, low volume metastatic disease. Now, there are ongoing trials to really assess this role of prostate-directed therapy in patients with oligometastatic prostate cancer in conjunction with surgery. And there's something called the SWOG 1802 trial, which is accruing slowly, but it's moving along, looking at either prostatectomy or radiation plus standard systemic therapy versus systemic therapy alone. And that will give us a much better sense, potentially. That's one of several trials looking at this role of surgery in these advanced prostate cancer patients. Now, you alluded to this question of stereotactic radiation, and clearly there's been a lot of interest in this. There have been a number of phase 2 trials looking at whether treating isolated metastasis may benefit the patient in that you're able to delay the initiation of androgen deprivation therapy or a change in therapy. And we have yet to have a very large phase 3 trial. Those are ongoing right now. But there are, I think, in this modern era, some benefits in selected patients with low volume disease to, especially if it's a symptomatic metastasis, to thinking about stereotactic radiation.
So, you've highlighted very nicely that, and I think it's one of the key messages that we want to have our listeners understand, which is that ADT monotherapy really in this day and age is really not the standard of care for the management of metastatic prostate cancer. We talked about doublet therapy, we talked about triplet therapy, and clearly I think monotherapy is really not where we want treatment to be in this day and age. But nonetheless, ADT is the backbone for all of these, doublet, triplet. So maybe I'll just finish off this podcast. Talk to us a little bit about ADT and probably what many of us will see and perhaps patients will ask, which is sort of the cardiovascular implications of ADT. And just talk to us about that, if you don't mind.
Certainly. And we didn't get too much into side effects, but, certainly as urologists, we are delivering androgen deprivation therapy in a number of different ways, not only with these GnRH agonists and antagonists, but also with these androgen receptor signaling inhibitors. So, these kinds of adverse events in androgen deprivation therapy are important. They consist of things like hot flashes, osteoporosis, fatigue. With regard to the hot flashes, they can be very debilitating for some patients. And, we can use things like venlafaxine or gabapentin to help mitigate some of the side effects associated with that. Obviously, bone health is very important. And there's certainly some other resources that deal with that issue. One thing is that's become more prevalent is some of the issues surrounding cardiovascular disease and androgen deprivation therapy. And this was recognized actually fairly early on when they looked at a number of meta-analyses that showed that patients that were on long-term androgen deprivation therapy had greater risks for cardiovascular events and death. So it's important when we start patients on these androgen deprivation therapy approaches that we do a careful evaluation of cardiovascular risk factors, making sure that we're paying attention to things, serum lipoproteins, other blood pressure, blood glucose, a number of other things like that, to really help mitigate some of the potential cardiovascular risks of starting these medications. So it's something we don't always think about, but certainly it's very important, and often getting a primary care doctor for these patients is critical.
Yeah, I think that's very well said, and it kind of dovetails with what you said very early in our podcast, which is that as our therapeutics in this disease space have expanded and survival is better, a lot of the long-term sequelae associated with being on treatments will surface, and I think you said it very clear, whether it's cardiovascular, clearly osteoporosis, weight gain, changes in body morphism with fat distribution, hot flashes. So I think you're absolutely correct that we probably need to think a little bit more broadly than just simply the cancer control element, but make sure these patients are really appropriately getting all these other variables that can be sort of thrown off or perturbed by long-term therapy, especially hopefully as life expectancy increases.
Mm-hmm.
Well, Dave, it's always a delight to do any of these programs with you. It's obviously you've taught the advanced prostate cancer course at the AUA for a number of years, enormously successfully, but it is nice to get about 30 to 40 minutes of your time just to pick your brain on these. And we really do appreciate you carving out some time out of your busy day to do this podcast with us.
Well, again, thank you for your invitation, and hopefully this will help some of the learners with this issue of a rapidly changing field in prostate cancer. And again, I would say there's a lot of really exciting things going on in this area. One thing I didn't really get into is sort of this whole area of neoadjuvant treatment of high-risk prostate cancer. And that's an area that we're very interested in. A number of groups are looking into this. So stay tuned. The field will continue to change.
And for our listeners, again, thank you for your time and your attention. For any more information, please visit us at auanet.org/university. And I would put in a plug-in for Dr. Gerard and Dr. Cookson do run a great advanced prostate cancer course that always is the day before the AUA annual meeting starts. And they really delve into the entire spectrum and obviously in greater detail than what we can cover. Dave, always good seeing you. I hope to catch up with you sometime soon. And again, thanks.
Good. Thank you, Jay.